renal tumors. So first we shall discuss regarding your upper tract urothelial cancer. Now it is the primary neoplasm of your ureter and your pelvis, and it is rare. It is usually seen in less than 10% of your urothelial tumors, most common in your adult men. The various risk factors include your tobacco consumption, occupations in dye, petrochemical and rubber industries, analgesic abuse, high arsenic content in drinking water, exposure to your cyclophosphamide, and presence of your chronic inflammatory conditions which are usually associated with your squamous cell carcinoma. Now, they usually present with your gross hematuria and have a long slender worm-like claws which are suggestive of your upper urinary tract involvement. They usually have a poor prognosis. The tumor is multifocal, associated with your carcinoma in situ in normal looking urothelium, due to which the recurrence of tumors in bladder after a successful treatment of upper tract disease is common, and you need to follow your long term bladder follow up with your cytology and cystoscopy. The investigation of choice is your CT urography, and your treatment consists of, in case of low risk, which is your unifocal less than 1 centimeter, low grade disease and no invasion, you have your endoscopic ablation and your segmental excision. Whereas in case of your high risk, you have to do a radical nephrectomy with your bladder resection with or without lymphadenectomy. So these are your few important one-liners of your upper tract urothelial cancer. Now moving down to the next tumor, we have your renal oncocytoma. This forms around 5% of your renal tumor. They have a high abundance of your oncocyte, usually seen in your 7th decade, more common in male compared to your female, coexist with your renal cell carcinoma in approximately 10% of the patient, and in radiology you will find a central stellate scarring and a spoke wheel appearance in your angiographic phase. Now this is your characteristics finding of a renal oncocytoma, and you usually treat it with a partial nephrectomy. So you have a spoke wheel appearance. This would be a spoke wheel appearance and a central stellate scar in your angiographic phase of your CT scan. Then the next renal tumor that we have is your renal angiomyolipoma. They are usually detected incidentally, have a more incidence in female compared to your males, and they are associated with your tuberculosis. Right. Please remember this particular part is very important, as you would be getting clinical scenarios where they would be giving a history of tuberculosis and asking you to diagnose the renal tumor. So you need to remember in that case renal angiomyolipoma is associated with your tuberous sclerosis. Now they may be sporadic in nature. Now pregnancy is a potential risk for your bleeding. In USG, they appear as a bright echogenic mass suggestive of a fat content, and in CT scan you have -15 to -20 Hounsfield unit within the mass, which is your hallmark of your angiomyolipoma. And your treatment consists of, if it is size less than 4 centimeter, you will follow up the patient. If it is more than 4 centimeter, you would go for a nephron sparing surgery, and if the patient is having an acute hemorrhage, you would do an angioembolization, and that drugs that inhibit mTOR has a good effect in tuberous sclerosis because it is associated with your activation of your mTOR pathway. So these are your few important one-liners that you need to remember regarding your renal angiomyolipoma, more common in females, a CT scan of -15 to -20 Hounsfield unit within the mass, which is your hallmark, and less than 4 centimeter you will follow up, and more than 4 centimeter you would go for a nephron sparing surgery. Then your juxtaglomerular cell tumor, you need to remember the one important point with respect to that: the hypertension resolves with surgery. So this can be asked as a one-liner important question. The hypertension in your juxtaglomerular cell tumor usually resolves with surgery. Now we have your renal cell carcinoma. This is the most common solid neoplasm of your kidney. Now the various classification and the salient subtypes of salient features of the various subtypes of renal cell carcinoma. You have your clear cell renal carcinoma. Now this is your most common subtype. It is usually sporadic and may be associated with your von Hippel-Lindau syndrome, that is loss of chromosome 3p and a mutated von Hippel-Lindau gene. Then you have your papillary type 1 and type 2 renal cell carcinoma. This is your second most common. It is usually sporadic, but it may be a familial. Now type 1 has a better prognosis compared to your type 2. Then you have your chromophobe RCC. This has a group prognosis and usually sporadic, but it may be familial. Then you have your collecting duct carcinoma, which is uncommon and aggressive tumor arising from the renal medulla, hence it is a centrally located tumor. And then you have your renal medullary carcinoma, which is again a very aggressive, having association with your younger age and your sickle cell trait and a centrally located tumor again. So please remember this few important points of your various subtypes. Important to remember is your type 1 papillary carcinoma has a better prognosis compared to type 2. Most common is your clear cell type and it is associated with your von Hippel-Lindau disease. Now various risk factors include your smoking, obesity, hypertension, diuretics and your occupational exposure in form of the dyes and petrochemicals. Now the classical triad that is associated is your flank pain, hematuria and palpable mass. However, it is not usually found in almost all the patients these days, but then still this is described as your classic triad of a renal cell carcinoma. So if you have the patients coming with these three symptoms, do remember to keep renal cell carcinoma as one of the most important differential diagnosis in your mind. Then a few specific one-liners. The most common presenting symptom is your hematuria and paraneoplastic syndrome occurs in almost 1/3. Now which is your most common paraneoplastic syndrome? That is your increased ESR followed by hypertension, anemia and hypercalcemia. And the most common site of metastasis is your lungs, where it is usually in the form of a cannonball mets. Now in diagnosis, you would definitely do your blood investigations to eventually check for your paraneoplastic syndromes, and then you do your measurement of LDH, which is used for your risk stratification of your disease. Now investigation of choice is your triphasic CECT scan. Now regarding your staging, you have this beautiful diagram given in your Bailey and Love. So you have your stage 1. When you have your tumor less than 7 cm in your largest dimension and the tumor is limited to kidney, right? So this is your stage 1. Then you have your stage 2, which is tumor is more than 7 cm and it is, the green one, more than 7 cm and it is limited to your kidney. Then you have your stage 3, where you have tumor in your major veins or adrenal glands with an intact geratofascia or regional lymph nodes involved. So when you see over here in your stage 3, the geratofascia has not been breached. Now there may be the tumor in your major veins or your adrenal glands associated, but there is no breach of your geratofascia. Now you have your stage 4. When you see over here, you have your tumor going beyond your gerota's fascia. So here it is beyond gerota's fascia, right? Now the prognosis is on the basis of your WHO and ISUP scale. The factors indicating your poor prognosis include your tumor size, venous invasion, renal capsular invasion and your adrenal involvement. Now for the treatment, the gold standard for your localized disease is your radical nephrectomy. Now if you have tumor less than 4 cm, then you would go for a nephron sparing surgery. Now this is usually done in selected cases of 4 to 7 cm, tumor size less than 4 cm, when you have a bilateral tumor and tumor in a solitary kidney and you have a pre-existing renal dysfunction. So these are the cases where you would go for a nephron sparing surgery. Now when you have cases with IVC thrombus, now what would you do in such cases? So over here the thrombus may extend as far as the right atrium and it has an association with around 5 to 10% of the cases. So the thrombus extending to the retrohepatic or the suprahepatic segment of IC require your full mobilization of your liver, whereas your thrombus extending to the right atrium may require your cardiopulmonary bypass and your circulatory arrest may occur in such cases. Now for your metastatic renal carcinoma, up to around 1/3 of your patients will present with your disseminated disease. Now tyrosine kinase inhibitors, which inhibit your vascular endothelial growth factor like your sunitinib and pazopanib, have shown to have an improved survival in your metastatic renal cancer. Then RCC is immunogenic tumor and responds good to your immunotherapy. The first generation of agents that were used include interleukins and your interferons. Now targeted therapy in form of an immune checkpoint inhibitors and anti-programmed death ligand inhibitors have been advocated. Now cytoreductive nephrectomy may be beneficial in good and intermediate risk patients. Palliative nephrectomy may be considered for intractable hematuria, pain and your symptomatic paraneoplastic syndrome. Then lastly, your injury embolization of your renal tumor can be performed in medically unfit with intractable hematuria where your surgery cannot be performed. So this were your few important points with respect to your renal cell carcinoma. Please remember your subtypes, your tumor staging and your management, specifically for your less than 4 cm where you would go for a nephron sparing surgery and the conditions where a nephron sparing surgery will be done. Now the last tumor that we have is your Wilms tumor. It is your most common tumor of childhood. It is associated with your 5% childhood cancer, bilateral in 5%, familial in 1%, usually occurring between age 1 to 4 years. Now, pain is uncommon, usually presents at large palpable mass that crosses your midline. The most common distant site of metastasis is your lung. And then you have a claw sign. What is this claw sign? So your tumor infiltrates the kidney and the normal renal parenchyma is compressed at the periphery. So the compression of the normal renal parenchyma because of the infiltration of the kidney by the tumor leads to the claw sign. Now it has mixed elements in your histopathology, which includes your blastomal, epithelial and stroma elements. Now the treatment would be your nephrectomy with pre and post-op chemotherapy. So this were your few important points with respect to your Wilms tumor. Thank you.